Hi, my name is Dr. Paul Haleska. I'm a medical oncologist and consultant at the Mayo Clinic in Rochester, Minnesota. I'd like to talk to you today about an innovative clinical trial that we're doing in HER2-positive breast cancer patients here at the Mayo Clinic, as well as sites throughout the United States. I'd like to talk to you a little bit about the rationale for this study, which patients are eligible, and then give information to patients about how to participate in the study at the Mayo Clinic, as well as sites throughout the United States.
N0733 is a phase 2 clinical trial in HER2-positive breast cancer patients that's investigating the addition of IMC-A12 to the standard therapy of capecitabine and lapatinib. I serve as the PI for this study, and Dr. Hannah Linden is the SWOG PI for this study. The rationale for N0733 is based on preclinical data which suggests that there's bidirectional crosstalk that occurs between the insulin-like growth factor 1 receptor, or IGF-1R, and the ERBB receptors, including HER2. We also know that breast cancer cells transfected with IGF-1 receptor become resistant to trastuzumab. IGF-1R is expressed in patients treated with lapatinib and capecitabine, and IGF-1 receptor inhibition increases HER expression and activation. The combination of IGF and HER targeted therapies shows synergy in multiple tumor types, including breast cancer. Here are some of the preclinical data that we have produced. You can see here in the red and blue bars on the left, these are single-agent IGFR or HER2 inhibitors as a single agent, which have little at these doses have little activity in stimulating cancer cell death, but when combined they have dramatic increases or synergistic death as far as apoptosis, as represented by the purple lines. And this is represented by the images of the cell nuclei on the right side of the figure. As you can see in these two models, IGFR inhibition alone, there's relatively little cell death. Same thing with HER2 inhibition, but when you combine these agents, you see many fractured nuclei or apoptotic cell death figures in the combination treatment. In this series of experiments, we investigated the hypothesis that ERBB receptor expression and activation was sufficient for resistance to IGFR inhibition. We took an MCF7 breast cancer cell line, which was initially sensitive to an IGFR inhibitor, in this case BMS 536924, and we forced MCF7 cells to express either EGFR or HER2. In doing so, we found that if we activated either EGFR with EGF or activated HER2, HER3 heterodimers with heregulin, we found that this was sufficient for overcoming sensitivity to IGFR inhibition. Thus, in HER2-positive breast cancers, this supported our hypothesis that co-targeting of the HER family of receptors in combination with the IGFR receptors was sufficient for substantial anti-tumor activity. And these, again, were supportive data for the N0733 clinical trial. So I'd now like to just go over some of the basics of IGFR signaling. The IGF-1 receptor, much like HER2, is a receptor tyrosine kinase receptor. It is activated by IGF-1 or IGF-2. Upon the ligand binding to the receptor is activated, which leads to a series of downstream activation of cellular proteins, leading to proliferation and survival. In HER2-positive breast cancer cells, the drug lapatinib blocks signaling through many of these cellular pathways. However, IGFR can overcome this by activation of the IGF-1 receptor. This is blocked by IMC-A12, which then overcomes this mechanism of resistance. Thus, the known major mechanisms of resistance to trastuzumab or Herceptin, including heterodimerization with EGFR or HER3, loss of the trastuzumab binding site, or expression of IGFR, are being targeted with either lapatinib or sixitulimab, otherwise known as IMC-A12. N0733 is a randomized clinical trial that will test this hypothesis that blocking the IGF-1 receptor will improve the therapy of capecitabine plus lapatinib. Patients who have previously been treated with Herceptin, have HER2-positive breast cancer, and previously treated with either an anthracycline alone or a combination of an anthracycline with a taxane or a taxane alone, and have at most one prior chemotherapy for metastatic breast cancer are eligible for consideration to be randomized into the study. As part of the correlative studies, we'll be collecting circulating tumor cells and serum for a number of correlative studies. We'll also be collecting immunohistochemistry samples on the primary tumor tissue, but I should point out there is no biopsies being done on this study. Patients will be randomized in a 2-to-1 fashion to the investigational arm of capecitabine plus lapatinib plus IMC-A12, or the standard arm of capecitabine plus lapatinib. Patients will be continued until progression or toxicity that warrants stopping treatment. Day 8 and day 22 of therapy will also be collecting additional serum samples for correlative studies. Inclusion criteria include HER2-positive breast cancer, locally advanced or metastatic, and previous treatment with trastuzumab. This is required. If trastuzumab was received in the adjuvant setting, the patients must have received a taxane, an anthracycline, or both, or a taxane, anthracycline, or both for metastatic breast cancer. Retreatment with a trastuzumab-containing regimen is okay if it's been greater than 12 months since patients have received their adjuvant therapy. If patients have not received any previous adjuvant trastuzumab, a single anthracycline, a taxane, or both. HER2 positivity is defined by IHC3+ or HER2 positive gene copy number greater than 6, or an amplification ratio of HER2 to D1771 of greater than 2.21. Patients must have measurable disease by RECIST criteria, must have normal organ function, including ejection fraction of greater or equal to 50%, fasting glucose of less than 120, and an ECOG performance status of 2 or less. Exclusion criteria are as follows. Patients must not have had 2 or more regimens for metastatic breast cancer or advanced disease. Other malignancies within 5 years, liver disease, active brain metastases, though patients with prior brain metastases that have been demonstrated to be stable after radiation therapy are okay and possibly allowed on study. Previous lapatinib or other EGFR/HER2 targeted therapies are not allowed on study, though trastuzumab is a requirement. Patients also must not have had a previous IGF-1 receptor targeted therapy. Patients also must not have uncontrolled diabetes or be an immunocompromised patient. This figure represents the correlative studies that are being done on this clinical trial. These innovative assays will help us understand the mechanism of activity of the combination of lapatinib, capecitabine, and IMC-A12, and whether our hypotheses are true about IGF signaling and its role in HER2-positive breast cancers. Among these include investigating the IGF-1 binding proteins as a determinant of sensitivity to IGFR targeting. We'll also be looking at the closely related insulin receptor on submitted tissues from the patient's primary tumor. Patients who have high levels of insulin receptor A isoform may also confer IGF signaling responsiveness, but are not targeted by the IMC-A12 and may be a mechanism of resistance. We also know that there's possibly other receptors in addition to IGF-1 receptor that may be signaling as a mechanism of resistance to HER2 targeted therapy. We'll be investigating these other receptors, including the VEGF receptor or EGFR, as a possible mechanism of resistance using circulating tumor cells, as well as looking at activating downstream signaling molecules, including AKT and ERK. For more information, you can go to these sites listed on this slide. If you would like to come to Mayo to participate in N0733, please call the number on your screen and tell them you would like to come to Mayo and see me for participation in the clinical trial N0733. And I'll do my best to see that you have an appointment to be seen by myself and screened for N0733. Keep in mind the eligibility criteria that we discussed before to ensure that you are a potential candidate for participation in this study. If you'd like to visit one of the other Mayo clinics in Florida or Arizona, the numbers are also listed on the screen. Or for any of the Mayo Clinic sites, you can go to the link provided at the bottom of the slide. Not everyone can make it to the Mayo Clinic. We can also not complete the study with accrual solely at the Mayo Clinic. As a result, there are multiple other medical facilities across our country that are accruing to this study. They are listed here in the next few slides. I will go through them quickly, but you may be able to stop these on the movie and get the information to call the offices to inquire about enrolling in N0733. In addition, you can get this information from the clinicaltrials.gov site that was listed on the slides 2 previous. At the end of the accruing sites, we'll also list my email and contact should you have questions. Thank you.